Okay, well, we have about 60 people, so I'm going to get started. Good morning and welcome to Medical Grand Rounds. It's my great pleasure this morning to have Dr. Paul Levy, who probably is no stranger to much of this audience. Paul and I go back to our training days with fellowship, and he was a chief resident in the 80s. Paul has been on the faculty at the U of R since then, since 1988. And most recently has been professor of medicine, and until recently has been chair of medicine at the U of R Medical Center. He stepped away from that relatively recently, but is still active with his work with the TB clinic and with pulmonary medicine at the U of R. His topic today is...
Okay, thanks, Prad. Appreciate a chance to get together. And as Prad was saying, I'd like to give you a bit of an overview today about some updates in the tuberculosis world, but this kind of hits near and dear to healthcare providers' hearts because of some recent changes in annual screening, which is why I've used the title, Have You Had Your Last PPD? So I'm going to give you a bit of a walk down memory lane a little bit on epidemiology and such, just a brief update on that, but also share some thoughts about some interplay with COVID, in fact. And COVID has, in essence, changed everything we do, both socially, economically, in the business world, but has had big impacts, obviously, in healthcare. But it even has found its way into impacting tuberculosis nationally and internationally. And then really the bulk of the talk will be this new approach to healthcare workers and annual screening. I call that section of the talk, What's Out? Meaning, are we going to get rid of healthcare worker screening? Are we walking away from isoniazid as our first line treatment for latent disease? And then I'll close with a very interesting paper that is really shaped my thinking on what really the lifetime risk of reactivation is. So we'll cover those, and I'll frame that in the idea of where things are headed. And that's this risk-based screening for healthcare workers, rifampin as our mainstay drug for treatment of latent disease. But then this, as they say, this new model of TB risk around the idea that really the risk of tuberculosis is much more front-loaded within the first couple of years after exposure, after PPD conversion and such. So if we take a walk back to the late 1800s, 150 years ago now, when the Mycobacterium tuberculosis was first discovered by Robert Koch and announced that really landmark discovery, it's hard to imagine that 15% of individuals in Europe, North America, were dying from tuberculosis. This was obviously a major health issue at the time. And it really was on the cusp of even understanding infectious disease as a contagious event. There was really, at that time, much a thought that consumption and certain illnesses, in fact, were kind of your makeup, your genetics, even though we didn't understand genetics back then. But different families and different even races and the like might be hit by consumption, which was the term used for that chronic, debilitating form of tuberculosis. But really the challenge of trying to educate the public about the contagiousness of tuberculosis as it was being discovered and worked out epidemiologically. And there were posters back then that really resonate with today's world in COVID. And this is one from, I think, in the 1920s and 30s. And I can't help but think that all of us on our COVID quarantines or COVID precautions, and you think about ways to fight tuberculosis with plenty of sunshine, an adequate diet, and adequate rest. Those are some of the, you might say, rules of good health and what we want people to practice today with COVID. And as healthcare workers, we're even talking about the importance of all that because of professional burnout and some of those challenges. But even in the home, back then, there was a real push to try to protect young children. And here was this, I couldn't resist this picture of a baby with the bib on that says, "Don't kiss me." And I can't help but think of all of us being tied up at home. I was kidding my wife. I said, she being not vaccinated yet, me going to work and being vaccinated. I think she has a t-shirt that says, you know, "Stay away, don't kiss me either," because I don't want to have COVID. And, you know, fast forward to the COVID challenge, we've all lived through it the past year. This public health initiative to raise awareness about COVID and how do you protect yourself wearing masks. We've heard that ad nauseum, but unfortunately have had so many failures in the public health domain. But those challenges today, just you look back and you think about some of those same challenges that were taking place with tuberculosis education. And while we're talking about COVID education in the community, I just a plug for the teachers in our community and nationally. Certainly COVID has been disruptive to us in healthcare, but we at URMC, we were actually partnering with some of our community science teachers and a lot of our house staff and a few of our faculty, myself included. We were working with science teachers in the community to raise awareness about COVID education, really under the, you might say, the slogan of COVID savvy students might be COVID safe students. And we were trying to bring medical education into the science classroom. But it was eye-opening for me to see the challenges of trying to run a dual classroom with students online and students present. And, you know, hats off to our educators in the community who have had to struggle through this past year. It really has been an uphill climb, much as we have had to deal with telehealth and the new patient care workflows in our own environment. So, you know, I was mentioning how COVID might actually impact tuberculosis, and it's not obvious on the surface why this would be the case. But there's some interesting reports from the World Health Organization that really I found striking. And they were pointing out that almost half of the global burden of TB comes out of 4 countries: India, Indonesia, Philippines, and South Africa. And when you think of these countries at risk for tuberculosis, they in fact have also had their challenges with COVID. And the WHO points out that the reporting and treatment of TB last spring, March, April, May, you can see these major downticks in reporting in India, Indonesia, Philippines, and South Africa that occurred during the first phase of the COVID outbreak. And some of this was related to critical resource diversions from the TB world toward COVID, but some of it was just being overwhelmed by the COVID illness itself. But you and I both know that tuberculosis didn't go away last spring, and it probably reflects that patients weren't getting access to medical care, to anti-tuberculous medications and the like. And the WHO is concerned that there could be as many as 400 excess deaths from tuberculosis tied into reduced access in these very vulnerable communities. And on that theme about kind of the vulnerability of society in different countries, there's an interesting interplay between COVID and economies and gross national product and nutrition. And it's been long appreciated that as GDP falls, when you look at various countries, the number of cases of TB go up. And there's kind of an increased burden of tuberculosis in these countries that are really under the gun economically. And certainly COVID has had a major impact in just our own US GDP, but imagine countries which really don't have the reserves and healthcare resources that we do. And then this graph on the right shows as undernutrition, malnutrition increases in populations, the rise and the relationship of tuberculosis. And there's a great concern that COVID is going to make these vulnerable populations even more vulnerable, and in fact have a resurgence of TB. So that's just kind of an interplay with COVID per se. I'm going to move into a little bit of an update on the Epi Epidemiology, and then talk about the new screening models that are going to be applied to healthcare workers and such. Well, I think all of us are aware that TB is a major health problem worldwide. A quarter of the world's population, in fact, is infected, meaning would have positive skin tests or positive IGRAs if they were tested regularly. And I think it's kind of not well appreciated that before COVID, tuberculosis was the leading cause of death from an infectious disease worldwide, with 1.2 million deaths in HIV negative individuals. If you add in people living with HIV, there were another 200 plus thousand deaths associated or tied in with tuberculosis. So nearly 1.5 million TB-related deaths on the international stage. And that's really sad because we know we have effective therapy for TB, which is why it's really labeled as having it really is one of the most common causes of a preventable death nationally, internationally, and such. But this infection, this kind of model of the tip of the iceberg being tuberculous disease here above the surface, and then the TB infection that is latent disease that kind of sits below the surface, that's where these 10 million new cases of tuberculosis, in essence, could develop annually across the globe. If you look closer to home, and again, in the United States being a well-resourced country, we've seen a nice steady decline. Certainly I lived through the late 80s and early 90s when HIV and TB really coalesced around a big uptick in tuberculosis. But the number of cases since the early 90s has been declining quite nicely, shown in this graph, with an incidence rate of somewhere around 3 per 100,000. And the most recent data, we've actually dipped below 9,000 new cases of TB in the United States as of 2019, with a case rate of 2.7 cases per 100,000. New York data is on a subsequent slide I'll share with you that shows the effect of the interplay with immigration and cases. And that's shown here on the national stage from the CDC. And you can see in these green histograms the kind of major wins we've had in US born cases across the United States with a real decline. But the blue histograms are non-US born cases. And I think visually you can see that that number hasn't really reduced much. The incidence rate has declined, but the absolute number of TB in the foreign-born remains a major problem. And nowadays, the foreign-born patients really represent a huge percentage of what we see in our local health department here and nationally. Here's the New York State data. I was mentioning earlier the uptick in TB from the late 80s and early 90s, and then this gradual decline that we've seen. But this next graph, I think, is so telling, where back in the early 90s, the percentage of tuberculosis attributed to non-US born individuals was around 20–25%. And now, as of 2019, roughly 85–90% of our cases of tuberculosis are tied in with non-US born individuals. And you can see that we've had some decline in the number of non-US born cases, but it's really reached a plateau and becoming quite a large percentage of our total burden here in New York State. And that's certainly what we're seeing at the health department at the county level. So what are some of the new changes that are out there, the new major themes that are coming up in TB world? And this is what I wanted to go over with you, is just recently the New York State Department of Health is finally addressing healthcare worker annual testing. And this is going to be abandoned and switched over to a risk-based screening approach. And I'll give you the data on how that evolved. And then we'll talk a little bit about switching from INH to rifampin as options for latent infection. And then lastly, I want to talk about this revision of the timeline between TB exposure and risk, because it's really shaping certainly my thinking at the health department when we see individuals who are referred with positive skin tests. So I know this is a big and busy slide, but this is from 2019 from the National Tuberculosis Controller Association and the CDC. And I just wanted to highlight the big change that the CDC recommended in 2019. Now it's 2 years ago that this came out, that they recommended no longer serial screening of healthcare workers. So not routinely recommending serial screening. They updated these 2005 recommendations, and we're switching over to a risk-based approach rather than routine annually screening healthcare workers. It took a couple years for New York State to finally make it through the regulatory process. But I want to take you through a little bit of the literature as to why this decision was made, and just to reassure you that I do think it makes sense. If you think of screening, we're obviously wanting to screen people that are at higher risk for acquiring infection, and also screening people who are at increased risk for reactivation of their disease. Because people who are in that category, you might say, have the greatest benefit of preventive therapy. If we were to put somebody on preventive therapy, it has its biggest bang for the buck in those at high risk for acquiring the disease and also at greatest risk for disease progression. But healthcare workers' risks have really changed over the past 100 years, let's say. If you go back to healthcare worker exposure to TB in the 1920s and 50s, there was no question that healthcare workers were in an increased risk group. And in fact, in the pre-antibiotic era, healthcare workers, some of them died related to acquiring TB as part of their profession. And the TB control efforts even had their roots in many of you in the audience. If too bad we're not in an auditorium, I'd be asking for a show of hands. I think many, though, remember the standard admission chest X-ray of the time. And the roots of that were kind of based on the idea that patients admitted to the hospital could have asymptomatic tuberculosis. And in fact, getting a film would at least make healthcare workers more aware of risk and hopefully keep it under control because of that screening. When you hear about that strategy and you jump forward to where we are with COVID right now and having every hospital admission COVID screened, it really is so similar, so parallel in today's world. But those admission chest x-rays, I think, as all of us know, have gone by the wayside. And it's truly because the number of cases of tuberculosis in the public domain has really declined. Back in the 50s, we were somewhere around 50 cases per 100,000. Jumped to the 1990s, it was around 10 cases per 100,000. And I mentioned on the prior slides, we're down, most recently, we're under 3 cases per 100,000. And again, back in the 80s and early 90s, there was nervousness among healthcare providers about risk for exposure to TB and the like. And we, in fact, do have data that showed an increased risk among healthcare providers, nurses, and other individuals. And you would see PPD conversion rates of 2, 3, or 4% on an annual basis. And when there was a facility outbreak, you might even see more positive skin tests showing up in healthcare workers. But if you look at the more recent data, and this is a report from the CDC that was published in 2012, it looked back from 1995 through 2007. When you look at healthcare workers, the annual case rates were starting to mirror the general population. So similar to even COVID today, the healthcare environment is fairly safe with all the precautions that we have in place. And in fact, healthcare workers did not appear to be at an increased risk for acquisition of tuberculosis. And so when you start seeing that annual risk of healthcare worker TB was approaching or even less than the general population, the thought was maybe we should be backing away from annual screening. And that brings up all of the evidence-based medicine problems of using PPDs and IGRAs, which are really pretty mediocre screening tests. They're good, but not great. And then you start screening lower prevalent populations, you really run into the problem of false positives and diagnostic yield and such. And this was a critically important paper from the Mayo Clinic back in 2018, where they reported their results of 40,000 healthcare workers who was screened over this 16-year period. And again, from up in Minnesota and such, it's not too much of a surprise. They don't have nearly the TB burden, for example, of LA or New York City. But even here, 40,000 healthcare workers screened over that period, 123 conversions, and only 9 of them appeared to be tied in with a true exposure. And what was really unsettling in this paper, and again, it's common in other papers we've seen, 2/3 of these people that we thought had converted, if you retested them, they in fact reverted back to negative on retesting, suggesting that the screening process was flawed and that most of these screened positive individuals were false positive. So we looked at our data here at URMC, and this is from Bruce Barron, courtesy of our occupational medicine program. There's roughly 75,000 employees that have been studied over the past 5 years. And you can look at the numbers and make the decision yourself. You can see that the yield was incredibly low of new conversions among this large number of skin tests. So the resources to bring people in, test them, have their tests read, et cetera, was enormous with virtually minimal to no yield. And so that led to the big decision to forego annual testing. But it was some of the annual testing, getting away from that, was also tied in with this important paper from back in 2014. And I remember giving grand rounds a few years ago at RGH, and for those of you who with long memories may recall this paper, but it was an important critical paper where 2,500 healthcare workers at 4 major academic centers were screened serially every 6 months. And what they found was this baseline testing, 4 or 5% people were positive, but very few people were triple positive, okay, meaning all 3 tests were positive. And I think we'd all agree that that probably is a true positive result. And 80% were triple negative. But the problem of PPD and IGRA screening really comes up in looking at how well does baseline testing hold up over time. And again, I'm pointing out that these individuals got serial screening. And so when you looked at the people who had positive skin tests and then you retested them, half of them reverted from positive back to negative. And if you looked at people who were baseline IGRA positive and you retested them, 60–70% of those people switched back to negative. So I'm setting the stage for explaining why we may need to be talking about double screening to feel comfortable that a positive test, in fact, is truly positive. And this same observation held true with conversion rates among healthcare workers. That prior slide was the baseline screening. So when you look at conversion rates by skin tests or by IGRAs, and this is a good place to point out that the IGRA skin tests, the interferon gamma assays, routinely have higher conversion rates than the good old-fashioned PPD, despite no difference in these individual faculty members or residents or nurses' exposures. And no one understands why the IGRA tests are showing us a marked increase in conversions compared to PPD. So be careful if you end up being tested with IGRA versus tuberculin as to what it means. But importantly, and this is really the important part of this slide, if you had a conversion from negative to positive, PPDs reverted back to negative. IGRAs reverted back to negative. And so at the health department, we in essence no longer accept a single positive test as evidence of a new conversion, unless of course that individual has significant risk factors for developing TB. So this paper by Dorman et al. Was very critical and really showed that healthcare workers in general are at low risk. The IGRA-based screening does have the problem with a very increased rate of conversions compared to tuberculin. And importantly, over 75% of these new conversions by PPD or IGRA revert to negative on repeat testing. So employee testing programs really need to be on their A game and be thoughtful about how they approach these screening tests. So this all led to the national change. The CDC published a new guideline back in 2019 that they were going to back away from routine serial skin testing or IGRA testing of healthcare workers unless there was some known exposure or an ongoing problem with transmission of TB at a given facility. So individuals would get a baseline screening when they joined an organization, and that baseline testing would be given to people who didn't have prior documented positive tests. But after that, no further annual screening. And if we jump forward to December of last year, finally, New York State Department of Health issued their guidance. and has gotten on board with the 2019 CDC information. And so this was one of the reasons I wanted to bring this forward from the health department perspective, so that your institution, I hope there's some people here from employee health, and they can chime in toward the end of the talk on how you hope to bring this new screening process forward. So Department of Health is following the national guidelines. There will be a risk assessment. They'll be asking individual employees, have you spent time greater than 1 month in a country that's has endemic TB? Are you immunosuppressed, HIV positive? Are you an organ transplant recipient? Someone who's on TNF inhibitors? That type of information is critical because of increased concern about progression to active disease. And then the third part of the assessment is, have you been in close contact without a proper masking and precautions with someone who has had active disease? So that's the screening process. And as far as testing goes with PPDs or IGRAs, that will only be for baseline testing of all employees unless they have a previously documented positive test. And annual testing only if you screen positive on some of these screening tests that I just walked through. So you will not need to be tested unless you have a risk screen. They did a nice approach to this. This is from, I found this at the California Department of Health. And they in fact have a kind of a checkbox approach to this for employees. Were you born or travel or had residence in a country? Are you immunosuppressed? Have you had close contact? If none of the above, you check this box, and no TB testing is indicated. So this was also reinforced by the National Tuberculosis Controller Association and the American College of Occupational Environmental Medicine. And they wanted to stress what I was really setting the stage for was healthcare workers who have a positive test and are unlikely to be infected with TB and low risk for progression. They really need to have a second screen to show that they're persistently positive. And in fact, as they say, when individuals from RGH, URMC get sent to the health department, we routinely are re-screening these low-risk individuals because there's so often a single screen positive and it's not a durable result, okay? So we would only offer people preventive therapy if both the first and second tests are positive. From here, I'm going to switch over to just quickly Valentine's Day last year, 2020. This article came out, it's a year ago this past week, where they have shifted the recommendations on treatment of latent tuberculosis. The focus now is on moving rifampin up to really the drug of choice. And this was an article from the New England Journal back in 2018. There's several articles in the TB literature that show higher completion rates when you use rifampin. This was a group of over close to 7,000 individuals that were treated with rifampin for 4 months or isoniazid for 9 months. And you get increased completion rates with rifampin. You had lower side effects. And in fact, they were non-inferior in this trial, showing the failure rate of rifampin was no different than the failure rate of isoniazid as far as cases of TB that developed during the follow-up period, which I think was 3 years in this study. And also reassuring about rifampin is this paper from Lancet Infectious Disease from 2019. And I show this only to emphasize that in these 3,000 individuals on rifamycin and isoniazid, the adverse event rates, that is hepatitis and other adverse events, were lower when using rifampin. And this paper actually also pointed out, they looked at age-related side effects. And in individuals who are older, 60, 70, 80 years old, you did not see an increased risk of rifampin-associated side effects that we often see with isoniazid. Now, the elderly or older individuals do have increased risks related to other medications they're taking, but they don't appear to be at increased risk specifically just from the rifampin and liver disease, for example. And so the CDC paper, again from a year ago, gave us these new guidelines, and this one wedged in the middle, the rifampin for 4 months tends to be our workhorse over at the health department. We do have a good number of people who are on a 3-month program of once a week rifapentine plus isoniazid. And then occasionally we have had some people on 3 months of taking daily INH plus rifampin. But we are shying away from isoniazid unless there's issues related to rifampin drug interactions and the like. And those in fact do come up. I think all of you on this Zoom are aware of how rifampin can really drive down drug levels and create other problems independent of isoniazid. So I'm gonna wind down with just a couple, these 2 papers, which are becoming my favorite recent papers. This was one from the British Medical Journal in August of 18 that came out. And it's a marvelous paper that really brought forward this notion that the timetable of tuberculosis is perhaps not what we have always kind of accepted. And at the health department, I don't know how many times I have seen individuals with positive skin tests and talked with them about a lifetime risk of TB being in that 5 and maybe upwards of 10% over the rest of their lives. And I'm finding that perhaps locking in on that strategy, which is really what the TB literature has supported for the longest time, perhaps is not as true as we would think it is. And these authors did a really wonderful job of pointing out how tuberculosis tends to be, active disease tends to be much more proximal to its exposure toward when you're in an endemic area, when you convert your skin test. And most of it occurs, probably 75, 80% of it occurs within that first 2 years of acquiring the illness, rather than leaving this long tail over the rest of your lives. And so these authors, and again, I'm not going to get into some of their historic review, but their paper from 2018 bore out in this recent, just fascinating meta-analysis, which was published in Nature Medicine in just last December of 2020. And these authors, this was out of the United Kingdom, they did an interesting thing with their meta-analysis. They used this technique called individual participant data in doing the meta-analysis. And this statistical technique has really caught on in the past 10, 20 years, really, where in contrast to a standard meta-analysis, you're actually doing a meta-analysis, but getting individual data on patients or enrolled subjects and using their specific individual data in the aggregate setting. And so what these authors did was they looked at a number of papers from low transmission settings, that is TB cases less than 20 per 100,000. And again, that's much higher than what we have here in the US, but still not nearly as bad as South Africa, Botswana, or some of these endemic areas. And so they ended up identifying out of these, I think it was 18 different studies across the globe, They had 82,000 individuals, and they had skin test data on them. 51,000 of them were positive, either by IGRA or by PPD. And then they were able to look at the incident cases of developing active TB. So this was a powerful, large database looking at risk factors and time course of developing active disease. It's really the largest number of patients that's ever been analyzed in this capacity. And they were in that cohort that they did through this individual data meta-analysis. They were looking at people who were close contact of disease, of TB, people with HIV, immunocompromised people, transplant recipients, recent migrants. And they followed them. The median follow-up was about 4 years. The interquartile range is here, shown here, 2.1 to 5.3 years. But their data were just fascinating. If you look at all participants, they graphed people who developed latent infection in the absence of any preventive therapy. And you can see on this graph, it approaches somewhere at 2 years, maybe 8 to 10% of all comers. But you can see that the bulk of the TB developed within the first couple years, and then there was this longer tail. And on this panel, I'd like to point out the green line are people who had latent infection, but started on preventive therapy, okay? And then this blue line are the people who were bona fide PPD or IGRA negative. And so clearly preventive therapy worked. People who were not infected, at least by screening criteria, didn't develop much in the way of TB. And then the people who didn't take their preventive therapy showed that augmented 2-year risk and then this longer tail. And that bore out with adults, recent migrants, again, that front-loaded 2-year phenomenon, even with the migrants who are from maybe endemic areas. And look at these children under age 15. By the way, I like to point out this vertical axis is much higher. It's 20, 40, 60% compared to these other panels, which are only from 0 to 20%. So kids under 15 had this 25% rate of developing TB, and it was so front-loaded. It was very early, proximal to when they probably acquired their illness, okay? This was such a strong observation. And they did some further modeling with the statistics to reinforce what I just showed you on those slides. If you look at people in various age groups, the younger people, this is 2-year risk data, when they modeled it out, the younger individuals had the highest risk versus older, much different here versus here. If you looked at the screening test result, they had individual data on the IGRA response and on the PPD response. And what that showed was the higher the IGRA or higher the PPD, the increased 2-year risk of developing tuberculosis. And there's just this big inflection point when you have people who are in the 75th or 100th percentile in their screening test result. And then they also showed the declining risk for people who had basically migrated many years earlier. So people who have, to use the expression here in the United States, if someone comes over to the health department, has been in the US for 25 years, their risk of TB is so much different than a recent immigrant. And so this paper really shapes at least my thinking on this, and I hope it has impact for you as well. But it tells me that, how do we aggressively offer latent therapy? And it's probably the young, recent immigrants, bigger PPDs, higher IGRAs. This is the population most likely to benefit from preventive therapy. And maybe we should be more conservative with some of our older, in the US longer, not immunosuppressed, foreign-born population. There's just ways to tailor this so that we can be more precise and more impactful with our therapy. And I've included the link here on this slide, and it's out on the web. These authors created a very handy decision analysis tool that you can load up patient characteristics, the PPD result, the IGA result, where are they from, how long have they been in the US, and they give you, in essence, a predictor of what the 2-year risk of developing TB is. And it's very, as I say, it's eye-opening when we plug in the data, and you see that you might need to treat 300 individuals in order to prevent 1 case of tuberculosis. And then when you see some of our young recent immigrants, and the number needed to treat is in the 20 or 30 versus the hundreds that I have for the previous example. So this Periscope TB calculator is something we're using educationally and also in the clinic to help us with deciding on who should go on preventive therapy. So I'll leave the presentation at that. Healthcare worker screening, what I'd like you to take away is that baseline testing remains intact, but ongoing testing annually is now no longer required unless there's a new risk, a new exposure. Treatment for latent disease is really focusing on rifampin rather than isoniazid. And as I say, these screening nuances for, I've mentioned the low risk healthcare worker individuals, we would commence treatment for latent disease only if double testing is positive. But I don't want to sound like we've given up on things. If we see a high risk individual, a lot of people in our community are on TNF inhibitors, on moderate to significant doses of steroids, cancer chemotherapy and the like. Those patients may need to be double screened and consider treatment if either test is positive. And we certainly lower the threshold for the PPD to 5 millimeters at that point. I'm going to put one last slide up and we can open it for questions. But this was addressed by the CDC, and I don't know if Ann Falsey was able to join this morning. But one of the questions came up because many of you in the audience I know were vaccinated with the Pfizer or the Moderna vaccine. The question came up, are vaccines coming into play when we start screening people for tuberculosis? And live vaccines such as yellow fever have been thought to perhaps create, at least cause negative PPDs, cause negative screening tests in certain screening efforts. And no one really knows right now what's going on in the setting of an RNA vaccine with COVID. I don't think anybody anticipates that it is going to have an effect on TB screening. But our current approach in the CDC in their letter, they basically said, why don't you just, unless there's a compelling reason to do the TB screening in the setting of the COVID vaccine, why don't you wait 2 months and then do the TB screening at that point? So I'll open it up there. Prad, are there maybe questions in the chat box?
So Dr. Falsey is there on the chat. I'll ask if, while we're looking at this Q&A, if we can find and unmute her. And if you know how to raise your hand. There she is.
There she is. You want to chime in, Ann?
Oh, yeah. Hi. So the question of skin testing, during active vaccination, with these new RNA vaccines is a big, I really have no idea. There's obviously no data, but they are such potent stimulators of innate immunity and cellular and humoral immunity. Good sense would dictate that you, unless there's a compelling reason that you have to, that you really shouldn't be doing TB screening during that period.
I have a couple of questions on the Q&A. One is, are international students screened before starting school?
That's a good question. In fact, we have partnered with U of R, RIT, and tried to get the word out. Different schools have had different approaches, is my understanding. We have tried to do that a little more in depth with international students, especially from Southeast Asia, given the high endemic TB load there. So we've worked at the health department, we've most closely worked with RIT, and I know Ralph Manchester, we've given some guidance to him over at U of R. But the smaller colleges, to be candid, I don't know what they are specifically doing.
Yeah. And then there's a comment, I guess, about migrant farm workers who aren't screened until the time they apply for permanent resident status, and that doesn't really seem fair.
Yeah. And we do see some of the migrant population, and it's not as complete and thorough as you'd like for all migrants, refugees, and the like. So it's rather porous how people can get into our community and our region without screening. When it is done, we obviously try to deal with it and get them over to the health department, because all the care through the health department is free, and the drugs, the monitoring, the films, etc.
Sure. And then Dr. Jackson asks, when do you do a second PPD? How long do you wait?
It's an excellent question. So let's just assume the sequence is as follows. For some reason, let's say you ended up with a positive skin test in someone who, if it's a healthcare worker and you thought they were relatively low risk, do you wait 1 or 2 months? Do you wait 6 months? There's some variability with me and my colleagues at the health department. We tailor it to risk. I do want to emphasize a single positive test in someone who's on Remicade is going to get respected no matter what. So we don't do a second test to confirm anything in someone who's immunosuppressed and such. But what you're describing is someone who maybe shouldn't have been tested in the first place, and they get they're going off to college and the college demands it or something. We would retest that person pretty, within weeks or so after the first test. I do want to raise one concern I have with the IGRA testing. There's actually literature, and they did this in that serial screening trial. If you have people who get a PPD, and even though we know PPD shouldn't cause someone to develop a positive PPD later, if you give me a PPD today, sometimes you'll see a slight IGRA response in the weeks that follow, and then it collapses back to 0. So you can get a transient IGRA in response to a tuberculin test. And so be careful on the test sequencing and what test you choose.
Sure. So there are a couple of questions here about BCG. can you just comment on that? What impact does that have on PPD? How do you take that into account in your decision making?
We've had a lot of discussion about BCGs at the Med Center. If we know an employee has bona fide BCG in the past, and they need to be screened, we think it's most appropriate that that individual be screened with an IGRA, because those won't be affected by BCG. The one caveat there is if we know someone had BCG and they also have a known negative PPD in the past, Dr. Barron might, because of economics of it, might just rescreen with a PPD because they've been negative and hopefully stay negative. So there's a little bit of uncertainty there. You can probably sense that in my voice on that. You know, so it is what it is.
You know, what about these folks who get the intravesical BCG for their superficial bladder cancers? Does that
we've
happen?
seen, you know, we've seen conversions with that, and those people, in fact, would be better off with the IGRA screening rather than tuberculin, just to try to avoid it. I still come back to, I'm very nervous about IGRA results. And this recently popped up with the ACM lab. We stopped getting the actual threshold of what the T-spot was, you know, how many spots were positive. These IGRA results, they shouldn't be viewed as a pregnancy test where a positive result is considered yes, you've got latent infection versus no. People who are right near the cut point, those are very often false positives, and when on repeat can come back as negative. And so if you have somebody, it's a little bit like that graph from the Nature Medicine paper. If you do a T-spot and they have greater than 50 spots, that's such a strong positive result, it is very unlikely that that's a false positive. But if you have somebody who has 7 spots or 8 spots and they are right on the cusp of positive, negative, indeterminate, those need to be repeated and looked at in context.
So I'm going to end with this last thing. I guess there was a comment that, you know, at RRH, we stopped doing routine annual TB screening, which is in line with what you presented. There's a question here about some assisted living facilities requiring a PPD prior to admission. Will this change with the new guidelines?
Yeah, and that's an excellent question. It's on my to-do list. I was going to talk with Annie Medina Walpole and also dig into the New York State regs, because I don't know that those have been relaxed yet in the nursing homes, because that's its own, that was actually one of the reasons there was such a delay with the healthcare document. But I haven't had a chance to actually look up what the regs are for nursing homes.
You would assume they would think of changing those as well, right?
One would think.
Yeah.
If someone on the call knows the answer to that, I'm all ears.
I don't see anyone jumping at that. We're just about out of time. So thank you very much, Dr. Levy. This was fantastic and timely as the rules have changed, and as you said. Thanks again.
If people have, if I could just add, if people have questions, obviously the health department really wants to be user-friendly. Call us, or we're starting to get into some telehealth efforts and the like to do better outreach into our surrounding counties as well, to build some bridges there. So
fantastic. Thank you.
Okay, thanks, Brad.